Welcome back, Focus Learners, to part 1 of our Joint Procedures and Orthopedic Coding Masterclass Explainer. I'm Harshal, and today we're laying down the absolute bedrock of orthopedic medical coding. In this highly visual instructional explainer, we're going to approach joint anatomy, physiological function, and mechanical classifications with, well, absolute clinical precision. Because look, whether you're assigning diagnostic codes or billing for complex surgical procedures, your accuracy literally begins and ends with your mastery of the anatomical site. So let's dive right in. Here's a quick look at our agenda. We'll be covering coding and clinical significance, synovial joint components, physiology and classifications, mechanical types, and finally, anatomy as your coding foundation. Kicking things off with Module 1, Coding and Clinical Significance. So you might be wondering, or maybe you already know, but it bears repeating, why exactly does anatomy dictate coding? Well, in orthopedic healthcare, surgical and diagnostic coding absolutely requires a rigorous, deep understanding of joint anatomy, physiology, and mechanics. When you're reading an operative report for a joint procedure, the physician's documentation is entirely rooted in the specific tissues they're interacting with, right? If you can't clinically distinguish between a dense fibrous joint capsule and a synovial membrane, or if you don't quite get the distinct mechanical leverage of a specific joint, well, you simply can't select the exact CPT code or assign the correct ICD-10-CM classification. Anatomy isn't just background knowledge here. It's literally the fundamental tool you use to prevent claim denials. Moving right along to Module 2, Synovial Joint Anatomical Components. Take a look at this cross-section of a healthy synovial joint. Notice the articulating bones at the top and bottom. Those are what provide the leverage. Between them, you can clearly see the boundary of the articular capsule wrapping the joint, and right there in the middle, that's the joint cavity, completely filled with specialized synovial fluid. Let's methodically break down these 5 core parts, kind of piece by piece. First up, the articulating bones. These provide our structural framework and leverage. Second, the articular capsule. This is a really dense, fibrous envelope that completely encloses the joint cavity. Third, we have the articular cartilage. Think of this as a super smooth, avascular hyaline tissue that reduces friction and absorbs shock when the joint bears weight. It's a true shock absorber. Fourth is the synovial membrane. This is the inner lining that actively secretes lubricating fluid. And finally, the synovial fluid itself. This is a viscous fluid with an incredibly unique, almost egg white-like consistency. Its job is to nourish the chondrocytes and lubricate the joint surfaces. For us coders, knowing if a disease affects the avascular cartilage versus, say, the fluid-secreting synovial membrane, that completely changes your diagnostic pathway. It's a total game changer. Now for Module 3, Physiology and Joint Classifications. You know, joints are responsible for so much more than just simple movement execution. Their physiological functions are actually highly complex. They provide essential skeletal stability and structural support. They maintain our posture, they coordinate our balance, and they give us that incredible ability to bear weight. Picture a patient walking into the orthopedic clinic. A disruption in literally any one of these functional abilities is exactly what brings them in, usually presenting with symptoms like stiffness, swelling, or just a total loss of mobility. So there are 2 distinct ways we classify joints, structurally and functionally. Structurally, meaning what the joint is physically made of. It could be fibrous, kind of like the immovable sutures in the skull. It could be cartilaginous, like synchondroses or symphyses, or it could be synovial, meaning it has that fluid-filled joint cavity we were just looking at. Functionally, however, we classify them by their degree of movement. Synarthrosis means the joint is totally immovable. Amphiarthrosis means it's slightly movable. And diarthrosis means it is a freely movable joint. Understanding this contrasting clinical language absolutely crucial when you're decoding medical records. All right, Module 4, Mechanical Joint Types Explained. Check these out. There are 6 distinct mechanical types that govern human movement, and their specific physical shapes completely dictate how they move. Some are designed for just simple sliding. Others act like literal door hinges for uniaxial movement. Some allow biaxial movement across 2 planes, and some are multiaxial, offering a massive, almost 360-degree range of motion. Let's actually map these mechanical types to specific functional examples in the body to make it concrete. The ball and socket joint allows multi-axial movement. You'll find this in the hips and shoulders. The hinge joint is strictly for uniaxial flexion and extension, exactly like your knees and elbows. Then there's the pivot joint, which enables rotational movement. We see this in the neck vertebrae or the proximal radial ulnar joint in the forearm. The saddle joint provides biaxial movement. A famous example is the first carpometacarpal joint at the base of the thumb, which, by the way, is the specific joint you can thank for your ability to text. The condyloid or ellipsoid joint also offers biaxial movement, found in the knuckles, or MCP joints, and the radiocarpal wrist. And finally, the plane or gliding joint allows for non-axial sliding, like what we see in the intercarpal joints in the hand and intertarsal joints in the foot. To tie all this mechanical function directly to physical locations, let's do a rapid, top-down anatomical tour of regional joint distribution. Up in the head and neck, we code for the TMJ and the AC, or acromioclavicular joint. Down in the chest, it's the sternoclavicular and costovertebral joints. Moving to the spine, we have intervertebral joints and the highly clinically relevant sacroiliac, or SI joint. The upper limb includes the shoulder, elbow, wrist, and those smaller MCP and IPJ joints of the hand we just mentioned. And the lower limb? That features the major weight-bearing joints, the hip, knee, ankle, along with the MTP and IPJ joints of the foot. So when an operative report states a procedure is on the MTP, you must immediately visualize its specific lower limb location and its mechanical type. It's all connected.
And that brings us to Module 5, Anatomy as Coding Foundation.
I really want to hammer this point home. Joint structure and anatomical site serve as the absolute foundation for ICD-10-CM disease classification and exact CPT code selection. Without a foundational grasp of joint anatomy, like knowing the differences between hyaline cartilage and synovial fluid, or keeping your biaxial joint straight from your uniaxial hinges, achieving diagnostic accuracy and preventing those dreaded claim denials is simply impossible. The site always dictates the code. Always. Look, almost every coding error out there ultimately starts with a misunderstanding of anatomy. By mastering the physical structure of the joint first, the codes just naturally fall into place. So, I'll leave you with this. If a single misidentified joint can trigger an audit or totally derail a claim, how solid is the anatomical foundation you're bringing to tomorrow's charts? That wraps up part 1 of this explainer. Keep building that foundation, stay focused, and as always, like, share, subscribe to Decode Healthcare with Harshal.